Hello, I'm Dr. Seiichiro Abe, Endoscopy Division, National Cancer Center Hospital, Tokyo, Japan. Thank you so much for inviting me to the also interview in gastrointestinal endoscopy. Today, I'm pleased to introduce our original article entitled Long-Term Outcomes of Endoscopic Resection and Metachronous Cancer After Endoscopic Resection for Adenocarcinoma of the Esophagogastric Junction in Japan, which was recently published in Gastrointestinal Endoscopy. The incidence of adenocarcinoma of the EGJ has been gradually increasing over time in Japan, as well as in the Western world. Endoscopic resection is a minimally invasive treatment option for superficial adenocarcinoma of the EGJ, which allows curative resection of lesion without lymph node metastasis while preserving the organ function. Endoscopic submucosal dissection (ESD) was developed and widely accepted in Japan, and it allows unblocked resection and on-zero dissection regardless of lesion size and location. And so far, several studies show excellent and short and long-term outcomes of the ESD for adenocarcinoma of the EGJ. And however, they were all single-center studies and has a relatively small sample size. Also, the results of these studies were confounded by the different criteria utilized in the assessment of lymph node metastasis. There is also a policy of data on occurrence of metachronous lesion after endoscopic resection in Japanese population. And our study group recently demonstrated that lymph vascular involvement, poorly differentiated histology, and lesion size were independent risk factors for metastasis in patients with adenocarcinoma of the EGJ. Patients with either mucosal or minimal submucosal invasion without these risk factors were unlikely to have the lymph node metastasis, and therefore they were ideal candidates for endoscopic resection. Thus, the aim of this study was to assess long-term outcomes and metachronous cancer in Japanese patients with adenocarcinoma of the EGJ after endoscopic resection, based on our criteria for the risk of lymph node metastasis. We performed our retrospective analysis of the patient who underwent EMR or ESD for superficial adenocarcinoma of the EGJ in 13 referral centers in Japan. The patients were classified on either low risk or high risk for lymph node metastasis based on histological features. The cumulative incidence of metachronous cancer, as well as overall survival and disease-specific survival rates were calculated. A total of 372 patients who underwent an endoscopic resection were included in the study. In the 5-year cumulative incidence of local recurrence were 13% and 0.5% in the EMR and the ESD group, respectively. The local recurrence rate in the EMR group was significantly higher than in the ESD group. During median follow-up period of 6.6 years, the 5-year overall survival rate in the low-risk group, the high-risk group with additional treatment, and the high-risk group without additional treatment were 93.9%, 77.7%, and 81.6% respectively. And for the same group, the 5-year disease-specific survival rate were 100%, 94.4%, and 92.8% respectively. The 5-year cumulative incidence of metachronous cancer in 316 patients without additional treatment was 1.1%. This study showed that no patient in the low-risk group develops lymph node distant metastasis. Therefore, this study supports that proposed risk criteria could be applied into the clinical practice for endoscopic resection of adenocarcinoma of the EGJ. These findings were almost consistent with Western guidelines and several reports from Western countries. And however, the findings regarding metachronous lesion in our study contrasted with the result of the publication from the West. The incidence of metachronous lesion was as high as 15 to 30% within the follow-up period of 3 years. However, the 5-year cumulative incidence of metachronous cancer in our study was only 1.1%. We believe that some differences in patient characteristics and definition could explain this discrepancy. First, A significant difference in length of variety esophagus exists between patients in Japan and Western countries. A long segment variety esophagus has been shown to be one of the independent risk factors for Metachronous lesion after endoscopic resection. And the proportion of long segment variety esophagus in our study was only 9%, and much lower than in other studies from the United States and Europe. Second, the length of short segment variety esophagus in Japan was supported to be shorter than that in the Western countries. Thus, the background and the high risk mucosal is more likely to be eradicated by endoscopic resection, particularly in ESD Japan compared with the Western countries. And third, to some extent, this significant difference could be attributed to the difference in the definition of metachronous lesion among studies. Lastly, there is a difference in treatment option and availability between Japan and Western countries. In Western countries, EMO followed by radiofrequency ablation in the standard of care treats any suspicious lesion on the remaining variety esophagus. And however, radiofrequency ablation is not commercially available in Japan. Therefore, prophylactic treatment for the remaining variety esophagus at the risk of metachronous lesion is rarely performed in our population. On the other hand, given the high success rate of the unblocked and outfield resection of ESD and lower incidence of local recurrence and metachronous lesion in Japan, and endoscopic resection alone is considered to be an acceptable and effective treatment amongst the Japanese gastroenterologists. In conclusion, favorable long-term outcomes with endoscopic resection observed in patients who met the low-risk criteria. ESD is a preferred treatment option for superficial adenocarcinoma of the EGJ in Japanese patients. Finally, not at the least, I'd like to acknowledge all members of our study group. Thank you so much.